Hello everyone, my name is Jacky. I'm a pediatric otorhinolaryngologist from Children's Hospital. In this video, I'm going to talk about some of the basics of flexible bronchoscopy and also the anatomy that we would encounter during a flexible bronchoscopy. A little bit background, Chevalier Jackson is the father of bronchoscopy, a father of bronchoscope. He first introduced the rigid bronchoscope. And then until 60 years later, Shigeto Ikeda, which is a thoracic surgeon in Japan, developed the first flexible bronchoscope in 1968. Until 10 years later, Wood and Fink published the first landmark paper discussing the application of flexible bronchoscopy in infants and children. There are various indications and contraindications for flexible bronchoscopy in children. I'm not going through each of them with you, but I would like to emphasize that patient selection is very important. You don't want to select patients with severe hypoxemia and also hemodynamic instability. For those cases, performing a flexible bronchoscopy, especially at bedside, could be quite dangerous. For the equipment, there are two kinds of flexible bronchoscope. Video bronchoscope is very popular nowadays given the lower price and also the better vision that compared with the fiber optic bronchoscope. However, video bronchoscope, the smaller size available is a 2.8 outer diameter bronchoscope, which can be a bit too large for infants. Especially those newborn or preterm babies. The fiber optic bronchoscope is a kind of an old-fashioned bronchoscope, but it has an advantage of being quite portable. You don't need the TV system, you can look through the eyepiece, you just need a portable light source. And also the smallest bronchoscope that is available is the fiber optic bronchoscope with a 2.2 outer diameter. This bronchoscope is very important, especially in infants, or especially in newborns, which as they can fit in a 3.0 endotracheal tube, which is the typical size for a newborn baby. Next, we'll talk about the anatomy that we will encounter during a flexible bronchoscopy. The following pictures and diagrams came from these three sources, and the atlas of a flexible bronchoscope is a very good pictorial illustration of the anatomy and also other pathology that we may encounter during a flexible bronchoscopy. Before we go into the anatomy of the airway, we'll first talk about the positioning of the patient. For flexible bronchoscopy, we can do it in two ways. One is we stand at the front of the bed with us facing the toes of the patient. The other way is we can stand next to the patient, we're facing the head of the patient. The difference is that the image or the pictures that we are going to see will be 180-degree reversed. So this is on the left hand side is the picture that we would see, or the view that we would see during a flexible bronchoscopy when we stand at the front of the bed. While on the right side is the images that we will see when we stand next to the patient. And usually when we perform a flexible bronchoscopy in children or infants, we do it in the first way, which means we stand at the front of the bed. We can insert our endoscope through the nose or through the mouth. By passing the nose or the mouth, the first anatomical structure that we are going to see is the larynx. This is the epiglottis, and going below the epiglottis is the vocal cord, the arytenoid, the epiglottic fold. From the larynx, we can see quite a lot. We can try to identify various pathologies that account for patient symptoms. For example, a very floppy epiglottis, retroferred epiglottis, a prolapsed epiglottis due to glossotosis. We can also observe if there's any laryngomalacia, any focal cord palsy, any laryngeal cleft, or other mass lesion. From time to time, we may also have a glimpse of the subglottis through the vocal cords, but sometimes it is difficult in a small baby. Going through the vocal cords, we'll enter the trachea. The trachea is a C-shaped cartilage ring with a muscular wall at the back. So this is the anterior tracheal wall, this is the posterior tracheal wall. From this picture, we can appreciate the trachealis muscle at the back of the posterior tracheal wall, which is a very important structure that served as a guidance when we are going further down to the trachea and the bronchus. This is a carina divided into the left main bronchus and the right main bronchus. The sequence of performing a flexible bronchoscopy varies from different practitioners. You may have your own way to do it. My way to do it is I start with the right side. At the carina level, I rotate my endoscope about 90 degree clockwise. And then I'll enter the right main bronchus. The trachealis muscle is now at the right hand side of the screen, at the 3 o'clock of the screen. At the top of the image, we will identify the first opening, which is the left upper loop. The left upper loop is sometimes quite difficult to be visualized because of its acute angle. Entering the right upper loop, this is the typical arrangement of the 3 segments of the right upper loop: the anterior, the apical, and the posterior segment. Going back a little bit, we'll enter the right bronchus intermedius. From the right bronchus intermedius, we can see the opening for right middle loop and the opening for the lower loop. The right middle loop is divided into the medial segment and the lateral segment. Going back a little bit, we will now enter the right lower loop. The first opening from the right lower loop is the apical segment of the right lower loop. This is the typical area where aspiration occurs, especially the patient has been in a supine position for a long time. This is the basal segment. Typically, the right lower lobe basal segment is divided into 4 compartments: the medial basal segment, the lateral basal segment, the anterior basal segment, and the posterior basal segment. So this is the right hand side. After that, we withdraw our endoscope back to the carina. After the right side, we will now examine the left side. At the carina, I would rotate my endoscope anti-clockwise for 90 degrees. Now you see the trachealis muscle is on our left hand side, and going further down to the left main bronchus. The left main bronchus is typically longer than the right side, and the angle is also different compared with the right side. At the end of the right main bronchus, we can see 2 openings. One leads to the lower segment, one leads to the lower loop, the other leads to the upper loop. Again, we will start with the upper loop first. The upper loop is divided into 2 compartments. One is the lingula, the other is the upper loop compartment. The upper loop is divided into 2 segments: the anterior segment and the apical posterior segment, instead of 3 compared with the right side. The lingular segment is also divided into 2, the superior and the inferior segment. After that, we will examine the left lower loop. Similar as right side, the first opening that we'll see is the apical segment of the left lower loop, and then we will enter the basal segment. The basal segment is also divided into a few compartments. Compared with right side, usually the left lower lobe only has 3 segments: the anterior, the posterior, and the lateral segment. And typically the medial segment is missing in the left side. Next we'll have a video demonstration of a virtual bronchoscopy. This is the software that we are going to run through during our workshop. You'll have plenty of time to go through some different scenarios and also to appreciate the normal anatomy. First we'll have a look into the normal anatomy before you go to the workshop. So the first structure that we will see is the larynx. This is the vocal cord. Going through the vocal cord, we will enter the trachea. At the posterior part, you will appreciate the tracheus muscle. Following the tracheus muscle, we go to the carina. At the carina, rotate my endoscope 90° clockwise to enter the right main bronchus. As you appreciate, the right upper loop is a very acute angle, and it's sometimes difficult to visualize all the segments in the upper loop. This is the apical segment of the upper loop, the posterior and the anterior segment. This is the bronchus intermedius. From there we can see the opening of the middle loop and also the opening of the lower loop. The right middle loop is divided into the medial and the lateral segment. This is the lower loop. This is the apical segment over there, and these are the basal segments: anterior, posterior, medial, and lateral segment of the basal lower loop. Now we draw our endoscope back to the carina. We rotate our endoscope 90° anti-clockwise to enter the left main bronchus. It's much longer than the right main bronchus, divided into 2 openings. One is the upper loop leading to the Lingula segment, and also the upper loop, which is the anterior, the apical posterior segment. And the Lingula loop is also divided into 2 segments. Next we'll enter the lower loop. Again, the first opening that we'll see is the apical segment over here, and then we will see the basal segment of the lower loop, which is typically 3 segments only: the anterior, the posterior, the lateral segment, and the medial segment is usually missing on the left side. After examining the left side, we withdraw our endoscope back to the carina, and from there we slowly retrieve our endoscope. Out of the trachea, but we will appreciate if there is any tracheomalacia, any external compression, any abnormality over the trachea while we withdraw the endoscope. Last but not least, at the subglottic area, we appreciate if there's any subglottic stenosis, and then finally withdraw the endoscope and finish the examination. So this is the normal anatomy that we will encounter during the flexible bronchoscopy. In our coming workshop, you will have you can play with different scenarios to go through some difficult airway anatomy and have a hands-on practice on the flexible bronchoscope. This is the end of the video. We are looking forward to seeing you soon in the upcoming workshop. Thank you.